this is nothing but MTP methods which I'm going to discuss now. In first trimester, suppose if mother came at 7 weeks saying that she has to undergo abortion, so what method will be the which one you are going to advise her is oral drugs. You will advise medical abortion, right? So very commonly that which we are following nowadays in clinical area, most common type in first trimester is your medical abortion. Very important. Medical abortion, which is nothing but I am going to give oral drugs to the patient. And but overall in first trimester, any woman, if it is she is coming to you and asking for abortion in first trimester, if you ask me which will be the best among all the methods, is suction evacuation. Okay, very important. It is suction evacuation. And in rural areas, to perform suction evacuation, we need electricity. But in rural areas, like very remote areas, there is no electricity. I am going to use a special instrument which is called as MVA syringe, and I'm going to perform a abortion. MVA means manual vacuum aspiration syringe. Okay, this I'm going to use and perform the abortion in rural areas. Now, there is one more instrument which we are using previously and not used nowadays. It is completely outdated, but yes, you have to remember for NORCET exam for your IBQ, that is your menstrual regulation syringe. Menstrual regulation syringe. Okay, and the last one which you can perform is DNC, that is dilatation and curettage, can be done in first trimester. Coming to the second trimester, if you ask me which is the best method of performing abortion in second trimester, the best will be drugs again, oral prostaglandin analogs, okay, which is nothing but your PGE1, that is misoprost. Okay, right. You can give misoprost, and other methods which you can follow in second trimester is extra amniotic, okay, ethacridine instillation. Ethacridine is a medicine that you're going to instill extra amniotic and intra amniotic into the sac. If you administer hypertonic saline, you can administer that, and that will abort and the fetus. And next one is oxytocin, and also we have surgical methods, and I'll come to that very soon. Okay, right, let us discuss one by one now. Coming to the first trimester abortions, see, if any just now I told you, right, if suppose let's suppose a pregnant woman came to me at 7 weeks saying that she has to undergo abortion. So what I'm going to advise her is, I'm going to take a kit which is supplied by the government of India. So what is there in that kit is, so there will be 5 tablets in that kit. See here, I have attached the kit here. Okay, there will be 5 tablets in the kit. Okay, a single tablet of mifepristone and 4 tablets of misoprost will be there. Okay, so single tablet of mifepristone, 4 tablets of misoprost will be available in this strip. And what I'm going to do is, so on the day on day 1, so okay, suppose she wanted to undergo abortion today, which is day 1. So I'll ask her to take this mifepristone. Okay, I'll come to that. Okay, so before that, let me tell you, medical abortion means here it is a OPD procedure. In first trimester, if you want to perform medical abortion, it is an OPD procedure. Okay, where the patient will come to the OPD and she will take the drugs and she will go to the home, right? Okay, so previously medical abortion was allowed till 7 weeks, but as per the latest guidelines of government of India, nowadays medical abortion in India, it is permitted till 9 weeks of pregnancy. Okay, on day 1, I will give tab mifepristone. I'll give tab mifepristone. What is this mifepristone? Can you people tell me what is the action of tablet mifepristone? Yes, be quick and tell me what is the action of tablet mifepristone. Yes, what is the action of tablet mifepristone? It is anti-progesterone. It is anti-progesterone. I've already told you in my previous classes when I'm explaining you the basic concepts in OBG. The one that maintains pregnancy is progesterone, right? If there is no progesterone, no pregnancy. So that is what the concept you're going to apply here. So no progesterone. Anti-progesterone analog you are going to give, that is mifepristone, you are going to give on day 1, and you will send her back to the home. What is the dose of trap mifepristone? Is 200 milligrams mg. You will give that single tablet and you will send back her home. Okay, and again you are going to call her on day 3 to the clinic. On day 3, what you're going to do, I am going to give her tablet misoprost, that is PGE1 analog, prostaglandin analog. Now, okay, now what is the action of this prostaglandin? Tell me, what is the action of this prostaglandin? It is uterine contraction. It will stimulate the uterine contractions and it will cause cervical ripening. And now what will be the dose? How many? I told you that in kit, 1 tablet of mifepristone and 4 tablets of misoprost will be there. Misoprost each will have 200 micrograms in it. Okay, right. So now see the dosage here. Now mifepristone she have taken on day 3. She came back to the clinic, and on day 3 what you're going to do is, on day 3 you are going to ask her to take the misoprost. How many tablets she should take is, yes, in less than 7 weeks she should take 2 tablets, or she, okay, less than 7 weeks she should take 2 tablets, or so each having 200 micrograms. I told you, right? 2 into 2 is 400, so 400 micrograms total dose she has to take. Okay, and route of administration, you can give either per orally or per vaginally, you can give this. Okay, now 7 to 9 weeks, in between this period, if the mother is coming and asking for abortion, yes, you have to ask her to take 4 tablets, all the tablets, all 4 tablets, 200 micrograms each. 4 tablets, 200 micrograms each. So what is the full dose? Total dose is 800 micrograms. So each tablet will have 200 micrograms. 4 tablets is 2 into 4 is 800 micrograms. Okay, route of administration is per vaginal administration. Okay, very important. So now there is a teratogenicity associated with misoprost, which can be asked in your tomorrow's exam. Okay, M for misoprost, M for Mobius syndrome. Very, very important. Mobius syndrome. Okay, right, which is something related to the fetus. Okay, which causes fetal anomaly. Okay, anomaly, right, mainly related to the facial muscles. Okay, next, on day 3 you will ask the patient to take this misoprost, and again you will send her back, and again you will ask the mother to come back to the clinic on day 15. Why? So on day 15 you will ask the mother to come to clinic to see whether the process of abortion is complete or not. You will check for the abortion, the process is complete or not. Okay, if the process is incomplete, still the products of conception is inside, still few fetal parts are inside, then what you are going to do, you will take a curette and remove all the products of conception, which is called as blunt curettage. You are going to do blunt curettage. Blunt curettage. Okay, and very important. So now coming to the suction evacuation. So suction evacuation is done from 9 weeks till 12 weeks. I told you in entire first trimester, uh, the best procedure to perform abortion is your suction evacuation. So this is done with from 9 weeks till 12 weeks. I told you till 9 weeks, which you are going to perform is medical abortion. You are going to give tablets, right? And so this is a special instrument by which you are going to perform abortion, right? This is called as Carman cannula. This is called as Carman cannula. Okay, and this Carman cannula, suction evacuation is done with Carman cannula. And see, the diameter of this cannula will correspond to that of the gestational age in weeks. Okay, for example, if a patient of 9 weeks should undergo a suction evacuation, then 9 mm catheter you are going to take. Okay, so Kelot, very fast. Okay, I'm going. If I'm going fast, you can ask me to slow down. Okay, right. So suppose, there is a woman who has to undergo abortion at 9 weeks. Okay, at 9 weeks, if she has to undergo abortion, so then you are going to take this Carman's cannula 9 mm. So that is what they are telling you here. Diameter in mm will correspond to that of the diameter in mm. This Carman cannula ka diameter in mm will correspond to that of the gestational gestational age of the uterus in weeks. Okay, just now I told you, right? 9 weeks pregnant, 9 mm. 10 weeks pregnant, 10 mm catheter you will take into the suction evacuation. So now let me tell you how suction evacuation is done. Okay, right. So just I told you, right, diameter in mm is will correspond to that of the gestational age in weeks, gestational age of uterus in weeks. Okay, right. So now let me tell you how this suction evacuation is done. It's very important to know. Okay, right. If I am going fast, please, you can ask me to, you can just text me, I'll make it slow. Okay, there's nothing in that. Okay, right. See here, till now you are clear. Anything should I want to explain, you people? Tell me anything should I want to explain. If you are feeling any difficulty, you can ask me. Just a minute. Any, if you, okay, all clear, right? So, okay, right. Then see here how suction evacuation is done. Now consider this as cervix. See, anything if I want to insert into the cervix, I need to dilate the cervix first. Okay. Cervix will be closed. Os will be closed all the time. Now I have to dilate the cervix. If I want to insert this Carman cannula into the uterus, I have to open the os first. So how I can open the os? So I have to take the Hegas dilators into my hand, and then I'll dilate the cervix. Okay, and then your os will open, and then I am going to take Carman's cannula and I'm going to perform the suctioning and remove all the products of consumption out. So this is called as suction evacuation. So again, let me tell you, you will get the suction apparatus. You will okay, right? And then to the suction tubing, you will connect the Carman cannula, and first you will take the Hegar dilator. You will dilate the cervix, and once the cervix is open, you will insert this suction catheter Carman's cannula, and you will remove all the, you will suction all the products of conception. So this is how the suction evacuation is done with Carman's cannula, right? So what will be the suction pressure that you should apply during suction evacuation with Carman's cannula is 600 mm of Hg. 600 mm of Hg. Okay, right. So now, can you tell me the complications? Complications? Any complications are you going to see during suction evacuation? Just now I told you, right? You should dilate the cervix, and then you have to insert the suction this Carman's cannula into the uterus, and right? Excellent, Rajeshwari. Yes, there is one rare complication which you can encounter when you are performing suction evacuation. That is your uterine rupture, perforation. Uterine perforation, very important. Uterine perforation can happen. Okay, so suppose you are dilating with the Hegas dilators uterus can get perforated. Okay, otherwise when you are performing suction evacuation, you can perforate the uterus, right? So it can happen with both. Okay, so suppose you are dilating the cervix with the Hegas dilators, and now you have perforated the uterus. Now what you have to do is, okay, you will just wait and watch. You will not do anything. You will just wait and watch. So please select the option called wait and watch. You will not do anything there. But if you are doing suctioning with Carman's cannula and you have perforated the uterus, now what you are going to do is, see, perforating with Hegas dilators compared to perforating with Carman's cannula, which is more dangerous. perforating with suction catheters is more dangerous. Okay, right. Perforating with Karman cannula is more dangerous. Okay, so what you will do, suppose now you are performing suction evacuation with the Karman's cannula and you have perforated the uterus. Now what you have to do, immediately stop the procedure. Immediately stop the procedure. Now don't remove the cannula out of the uterus. Immediately take her to the operation theater and immediately laparotomy need to be done. Okay. So this is how management will should be done. Okay. Right. So what is the rarest complication which you are going to face during suction evacuation is uterine perforation. Okay. Right. So next, coming to this, see the instrument here. Can you see a instrument here? What is this instrument called? Can you people tell me? It can be asked as an IBQ in your tomorrow's exam. It can be asked as an IBQ in tomorrow's exam. Tell me, what is this called as? Fadafat se tell me. Yes, this is called as MVA syringe. This is called as manual vacuum aspiration syringe. Okay, right. So the capacity of this manual vacuum aspiration syringe is 60 ml. Okay, so what you will do is you will just pinch and you will just insert the Karman's cannula and to the and then you will, okay, you will apply the suctioning, you will insert the Karman's cannula and then you, okay, so then all the you will suction all the products of consumption. Okay, right. So this is called as manual vacuum aspiration syringe and this can be asked as an IBQ. Please do remember, otherwise take a photograph. Okay, and okay, so just now I told you suction evacuation. This MVA syringe I am going to use in village areas where there is no electricity, in remote areas where there is no electricity. I can use this instrument which is called as MVA syringe, right? So it is done in rural areas. Okay, rural areas where there is no electricity, where there is no electricity. And please do remember, it has two valves. How you will identify in your tomorrow's exam, there is one more syringe which is called as menstrual regulation syringe. I'll show you that also. Please don't confuse between manual vacuum aspiration syringe and menstrual regulation syringe. Both are two different poles. Okay, right. So how you will identify the MVA syringe? Entire pura syringe will be white and it will have a two pinch valves. See here, one. So two pinch valves it is going to have. So that's how you will identify MVA syringe. Okay, right. So it has two pinch valves. And what is the capacity of MVA syringe? I told you already, the capacity is 60 ml. And how much pressure is generated is 660 mm of Hg. Is the pressure that is generated via this MVA syringe. Yeah. Any doubt, Mariammal, Pratibha, Ratnakumari? Please tell me what is the doubt your people are having. Tell me. Let me clear your doubts. I think you people are raising your hand. Any doubts? If you have, you can text me. I'll give you some time now. Okay. So no doubts, right? So there is one more instrument which will be looking similar to that of your MVA syringe. That is called as menstrual regulation syringe. The capacity of menstrual regulation syringe can be asked in your tomorrow's exam. Please do remember it is 50 cc. That is 50 ml. Okay, and the menstrual vacuum aspirate, this menstrual regulation syringe will look like this. Okay, it will have only one pinch valve. Okay, and this is how it is going to look. No more details on this because it is outdated, no more use nowadays. Only will be asked in your IBQs in your AIMS exam. Okay, right. Now coming to the second trimester. Okay, clear till here? Okay, anything should I need to give more clarity or more any, should I need to re-emphasize anything here? Please tell me. Otherwise, I'll proceed with my next slide. Okay, Jansi Rani is telling clear. Okay, so shall I proceed with my next slide? Okay, okay. Lakshman Yadav, okay, clear. Thank you, Lakshman. Others also tell me if you don't have any doubts, I'll proceed with my next slide. Otherwise, if you have any doubts, you can ask me now. Okay, clear. Ratnakumari, Kiloth, okay. Bhuvana. So now, abortion, I told you, right, it is a little bit lengthier topic. Only abortion, it will take 1 hour. Okay, remaining all other topics, I can explain it a little bit quicker. But abortion, I'm also covering the MTP, right? So it will take little bit time. MTP ka methods, abortion ka types and management, everything. So it's abortion, it's little bit lengthier topic at very, very important. Okay, right. So now, coming to the second trimester abortion. See, second trimester abortion, the best method is also giving oral drugs, which is called as prostaglandin analogs, misoprost, right? See, in first trimester, I told you that the mother will come to the OPD, she will take the drugs and she will go back to the home. That is an OPD procedure. But here, if you want to do, even if you want to give oral drugs, here in second trimester, you have to ask the mother to get admitted in the hospital. Okay, it is an inpatient procedure, very, very important. And misoprost, I told you that is the best which you can give in second trimester. Okay, after 12 weeks, you can give this misoprost, okay, which is a prostaglandin analog, PGE1 analog, okay. And please remember a thumb rule here, which is 444, very important. Okay, this is a formula which I'm giving it to you to remember this. Okay, so the dose of misoprost is 400 micrograms. Frequency, how frequently you are going to give misoprost here in second trimester for abortion is every 4th hourly you have to give misoprost. And how many maximum doses you have to give is maximum 4 to 5 doses you can give. Okay, so all 444, right? All 444, 444. So please remember this 4 is to 4 is to 4 thumb rule here in case of second trimester misoprost administration. Okay, right. So next, coming to the surgical methods, you can go for dilatation and evacuation. You will just dilate the cervix and then you will take the ovum forceps. Okay, and then you will remove all the products of conception out. Right. So how, now you will ask me what is this ovum forceps? So how to identify ovum forceps? See the tip of the ovum forceps, which is spoon shaped, right? That is called as ovum forceps. Okay, right. So now this and this is one identification feature, and one more identification feature is it will not have any ratchet lock. Very, very important. That means it will not have any lock. Have you seen artery forceps, mosquito forceps, where there will be lock, ratchet lock, niche, kinda? Okay, so but here there is no ratchet lock. And can you tell me one more forceps where there will be no ratchet lock? And don't tell me thumb forceps. Okay, now tell me what is that one more forceps where there is no ratchet lock. It is cheetle forceps. Okay, do you remember what is cheetle forceps? There will be a forceps which is kept in a bottle, methylated spirit, and used to take all the sterile gauze pieces and everything, right? So which is called a steel cheetle forceps. And this cheetle forceps along with this ovum forceps will not have ratchet lock. Okay, right. So please do remember what are the identification features of ovum forceps. The tip of the ovum forceps is spoon shaped and it will not have ratchet lock similar to your cheetle forceps. That's how I am going to identify ovum forceps. Okay, right. Now, so the number one surgical method that you can do is you can dilate and evacuate using ovum forceps, right? And which is followed by, I have to do something called blunt curettage. Okay. Also, you can do blunt curettage followed by this. Okay, blunt curettage, except in molar pregnancy. In molar pregnancy, you have to do sharp curettage. You have to do sharp curettage. Okay, and there is one more surgical method that you can follow in second trimester. Final option this is, that is mini cesarean section, which is nothing but hysterotomy. You will do a mini cesarean section, you will open and remove the fetus out. Okay, that is called as hysterotomy.